the basis of me doing this talk more with less is because of the experiences that I had in Ethiopia after I finished my residency. I served in a couple of advisory roles, and the funny thing about it was the lessons that I learned there, some of them were applicable to the things I saw as a physician here. And I thought it'd be helpful to share it with the audience and to whoever else watches this. So there needs to be a new paradigm that defines global health. It should, in terms of its practice, it should assist building of something of value that's sustainable when you leave for those resource-limited healthcare systems. And those same practitioners should come back with this new perspective and applicable skill sets to apply in those resource-rich settings. Now, this slide, in that context, is both informative and really disturbing. Basically, it says, if you live in a country with blue, you have a higher ratio of physicians to patients, to population. If you live in a place with a very light shade of blue, it means that you have far, far fewer of physicians per population. So to look at this in even more detail, these are the two countries that I'm most familiar with because I work there, Ethiopia and the United States. And the ratio of physicians to 10,000 people in the population is 0.3 in Ethiopia compared to 24.2 in the United States. That's an 80-fold difference. So you can imagine the consequences in terms of delivering care to patients, to training future physicians. That's not even factoring in things like urban versus rural settings, where physicians are more likely to go, or private practice versus working for the government. This is a tremendous challenge. And as one of my colleagues says, you can't have a healthcare to provider system without providers, right? So this is Debre Berhan University. 10 years ago, this was farmland, and within the last 10 years, they built a university that actually has 7,000 full-time students. And in addition, it actually has a new medical school, Debre Berhan Medical School, which, with full disclosure, I lectured at, I wrote some of the curriculum for, as well as helping support the launch of the other medical schools that was already mentioned. Now, we can build more medical schools, we can supply more supplies, and that's what a lot of the multilaterals are now doing in global health. That's one of their goals, and that's important. But bricks and books aren't enough, and we'll talk about that in a bit. So we're gonna have a case study, fun little medical case study, if you will. Let's introduce a patient. His name is Mr. Sick. All right, Mr. Sick is a 65-year-old obese and diabetic male who hasn't seen a doctor in several years. He presented to a local hospital at midnight with a very bad urinary tract infection, some abnormal vital signs, abnormal labs, and some back pain. So he was assigned a diagnosis as early sepsis. Sepsis means you have body-wide inflammation and you have a singular source. And the goal is to treat it early and aggressively, and if you do, you're pretty much in the clear. And if you don't and you're delayed for whatever reason, depending on what's causing the sepsis, it can progress very quickly and you can have many complications, and beyond a certain threshold, about the majority of them die actually. So this is very important recognizing in a timely fashion. So the hospital course of this patient is, we had difficulty arranging for a diagnostic study because he presented a little bit differently. And so it took a few hours because we didn't have the staffing resources available. We had inaccurate vital signs recorded for this patient. In other words, the nurse had used a thermometer that said one thing, and eventually a member of the team walked by and said, "Hey, he doesn't look too hot. You sure those numbers are right?" They did it with that same thermometer, same number, and they asked for a different thermometer, different number. So that is clinical acumen, but because of the delay, it actually caused a delay in recognition of the clinical deterioration. And the third aspect was, once we actually got the imaging studies back and we figured out what the cause of the sepsis was, it needed to be intervened on immediately. So this emergency case actually took 6 hours before the person doing the procedure could come in and successfully do the procedure. So this is an emergent case, and I told you, you wait too long, things happen, right? So this patient actually started entering septic shock, which is the form that's associated with death. Luckily, this patient made it by a very close margin, and it worked out, and a member of the administration came to my team and thanked us for what we did, said, really did a good job, and said, this isn't reproducible. We don't have the resources. physical and human to get this done, let alone at that time of night, even during the day. So the question is, how often does this happen? Where does this happen? And if I ask you where this occurred, this is your global health quiz at 10:45 in the morning, is, do you think it happened in Debre Berhan, Port-au-Prince, Haiti, Chicago, New York, San Pedro Sula in Honduras, or Omaha? Answer is actually New York City. So when I say the provision of healthcare has challenges universally, I mean that. But the irony is I had the exact same conversation a year later in Debre Berhan, Ethiopia. So this is a challenge, the provision of care, the basics from making the correct diagnosis of a patient, having the equipment to understand the extent of disease, having the clinical acumen to figure out how quickly and how badly the disease is progressing. And the last part is coordinating the resources you have in an institution to make things work. When I talked to you about that sepsis case, sepsis, if you recognize it early, all you need are fluid and antibiotics. The problem is when you take too long to recognize it, you know a whole bunch of other things. So this is a challenge that you have coordinating patients in the United States. You have a whole bunch of people you've got to coordinate with around the patient. And you've got to do this for each patient, right? So there's a lot of coordination logistics you can imagine. So being as such, this actually inspired me when I was in Ethiopia, and I worked as a quality improvement advisor at a hospital there, Debre Berhan Hospital. And we had a mandate from the Ministry of Health to actually reduce the time to the initial clinical encounter. Now, you hear initial clinical encounter, your first thought is, throw some more doctors at the problem. Oh wait, this is Ethiopia, where the ratio is 0.3 physicians per 10,000. So that's not an option. But if you look at this diagram, and anything that has a bullet point is a delay point. So this is a delay, this is a delay, these have delays. These are tracked for a patient basically during the course of the day, from beginning to end, to either when they got admitted or they went home, right? This is the outpatient setting for the hospital itself. So the challenge is, how do you address the delays if you don't have more doctors? Well, we were able to detect 2 delays upstream from where the doctors were, right? It's the chart room, because they basically had charts in 4 different rooms scattered across the hospital, and the cashier, because we only had a single cashier processing things during peak times. So what we understood then is, what if you redistribute personnel from where they're not needed during the peak times to where they are, and see what happens? And we got the times down. And all it took was following people throughout the course of their getting provided care. And that's something we can do here, and it's a part of the research that I'll be doing here this summer, actually, at the University of Chicago. Encouraging change. This is why we all go abroad. We don't just go to work as individual practitioners. We actually want to improve the system as a whole. And this is a part of a nursing-led quality improvement reform where they standardize their hours to improve healthcare outcomes. And we're going to come back to this in a second. This is from Dr. Abraham Verghese, who's a professor at Stanford Medical School. And I approached him because I was born in Ethiopia, but in full disclosure, I left when I was 11 months old. So I didn't speak the language very well, I didn't get the culture very well, and I was afraid of being a bull in a china shop, essentially. And so I approached him and I asked for advice, and he said, go in humility, listen a long time, be very careful in what you say and do, and they'll be very grateful. And it was absolutely true. This was the first step in me getting buy-in. The next step, I'm at University of Chicago, I've got to throw in a President Obama reference. The next step is Yichala, and this is derived from 2008 when there were Ethiopians for Obama, and they translated Yes We Can into Amharic, an Ethiopian language, Yichala. So this came up when I was at the hospital, and whenever there were obstacles and you approached the right person with institutional knowledge, you know, if you approach them the wrong way, they'd be like, I don't think we can do it. But if you said, do you think we can do this? Like, Yichala way? And then the answer was, Yichala, right? So whenever someone asks you, can you do something, I want you all to say, very good. You now know more Amharic than I spoke at the age of 26, sadly. All right, so, and the third part is mentorship. The reason I ended up there was because of a pairing between my hospital, where I trained residency, and this hospital, Debre Berhan Hospital. And basically you had exchanges for a week at a time from leadership and personnel, so they got to see different ways of doing things. The the staff in this hospital came back invigorated, seeing how different things are done, different things are capable, and it was amazing. And it was in part fostered by these two nurses, Judy and Jackie, and they actually mentored the nurses there. And they gave them a different perspective on how to do things. Similarly, Dr. Frisaha, who I have to mention briefly, this physician who was born at this hospital, worked there as a general practitioner, has been an obstetrician as well as an executive at the hospital for 15 years now. And he was a mentor to me in showing me how to work with the system and how to gain buy-in. So mentorship actually goes both ways. I mentored students, I mentored junior faculty, and I got mentored as well. Resource limitations are a big challenge in this setting. Less supervision, what does it lead to? You basically don't have enough people to teach. We already talked about that ratio of relatively few physicians. So what happens? Students have to learn on their own. They're not supervised. They're largely memorization-based and individual training. They develop bad habits because they're not role modeled sufficiently. The other aspect is they have high patient volumes. I showed you that graph of the initial clinical encounters, right? Well, you think about it, they're staffing 3 to 4 times the number of people we would see in a clinic. And so they've got to basically see a patient in 3-4 minutes. What can you do in 3-4 minutes in an outpatient clinical visit? Get your jacket off, introduce yourself, say what your problems are, and put your jacket back on. So it's a tremendous challenge, but this is the environment that's been created because of the limitations. The question is, going forward, is it enough to build medical schools? And the reason I argue it's not enough, it needs to be done, is you need to have the proper supervision for these students. They need to be role modeled. They need to be shown what is right, what is wrong, how to be patient, clinical judgment, like we mentioned earlier. Now, the interesting thing is, this has not been recognized, even though you're building these medical schools. You're going to get them through medical school, and then what? They're not going to have anyone mentoring them. And this is a challenge not just in Ethiopia, but even in the United States, where there's an increasing body of literature, including some colleagues here from University of Chicago, Drs. Aurora and Dr. Farnan, where they've actually shown that supervision, there needs to be more of it to role model students and residents in terms of identifying patients quickly, correctly, and accurately, and that actually affects outcomes to some degree. So the solution is not just build, baby, build, but it's also supervision, baby, supervision, all right? So, to recap, the challenges to providing care are also universal. Coordination is difficult but possible when you put in the resources to figure out what's going on. By watching others do more with less, you not only get buy-in, but you get a better understanding of what they're going through and the challenges that need to be overcome. And you cannot realistically have supervision when you have scarcity. So the layer to add on top of this is, with these future global health programs, they need to send over residents to role model other residents, peer-to-peer mentoring for a prolonged time, which doesn't currently really exist. And? Very good, thank you.